Yeah, well, that's a little out of my,
Perfect. Podium it is. We're going to do podium.
yeah, I heard that.
Oh, whatever you think. Are we going to, are you going to introduce or?
Yeah, I'm going to introduce you both very briefly, and I'm going to switch to the other side of what we use the podium so that I'm
Yeah, so we're not switching.
people don't think I'm like making faces behind you. And
Oh, about anyone that is either part of the health plan or.
then I'm going to probably have a student.
About, I think 25 minutes, 25 minutes.
Okay.
So not too long. My understanding is like, yeah, I mean, and what's better?
That's perfect. So if we go both together, we have some time to chat. So you guys both I'm going to see if you want to comment on each other, and then
Yeah.
we'll take questions, and then I might invite people on each other.
Okay. Anytime you're doing a medical examination, that's when these rules, or asking questions about health.
Good. We'll just ignore them, yeah. You gonna do what? Yeah. Okay. And so we have 20 or 25? 25 is perfect, yeah.
I mean, if you stick it at 20.
No, that's good.
I mean,
Yeah,
I'll go quick maybe.
Kind of speak from here.
yeah.
Oh, I think we're gonna. Yeah.
Okay, and I'm going to
That's
do
the click. Yeah, got it.
clickers here.
Okay. Sure. Yeah. I hope so. Those are my slides up there.
Yeah.
We can mix it up. That'll be actually.
I'll do. Have you ever? I've had that where like you go to a conference, like where someone presents, you kind of present each other's work and then comment. You ever done that?
No, I haven't done that, but we did that last week in class when one of our students did one part of the slides, and I said, because he worked on that topic at postdoc, and I said, you can use these your own, and then he just used mine. It's so weird having somebody else talk about my slides. He did it better.
Yeah.
Scan this.
Sometimes that's how it works, right?
All right, welcome back. Thank you for sticking it out on a Friday afternoon with such wonderful weather outside. We're going to continue our examination of some of the policy and ethical issues that arise from wellness programs, and I'm going to briefly introduce our two speakers and then turn it over to them. First, we're going to hear from Professor Jessica Roberts, who is the director of the Health Law and Policy Institute and an associate professor of law at the University of Houston School of Law. And then we're going to hear from Dr. Harald Schmidt, who is an assistant professor in the Department of Medical Ethics and Health Policy and a research associate at the Center for Health Incentives and Behavioral Economics at the Perelman School of Medicine at the University of Pennsylvania. And they're, as I said, both going to further our discussion of some of the ethical and policy issues that are raised by corporate wellness programs. So without any further ado, I will turn it over to Jessica.
So thank you so much to the organizers. This has been a fantastic experience so far. And in keeping with our afternoon being critical of some of these kinds of programs, Sam talked about how disability can affect wellness program participation, and I'm going to talk a little bit about how social and environmental factors as well can provide barriers, and this is something that Sharona, I think, alluded to in her question during the last session. So as came up in this morning, right, wellness programs are not always effective, right? This might be putting it mildly under some circumstances. So one question, though, for us to consider is, why do we have this limited effectiveness? And one of the reasons why could be that not all employees can actually benefit from the sorts of things that these wellness programs might offer, right? And if some employees do not benefit, the absence of a benefit might raise certain issues with respect to social justice and access to healthcare, depending on which employees those might be. So I made the decision to frame my presentation in terms of nudges, which has been a very popular kind of a buzzword within the health policy literature recently. So to give you all a sense of what I'll discuss in the next few minutes, So to give you all a sense of what I'll discuss in the next few minutes, first I'll give you an introduction to this nudge theory, sort of what the basics of nudge are, and then the idea of corporate wellness programs as a particular type of choice architecture. Then I'll say a little bit about the role of autonomy and choice, just in behavioral economics generally, and ways in which there are certain barriers to healthy decision making that we frequently hear described as the social determinants of health, so things that get in the way of people making better choices related to their health. And then I conclude by discussing ways in which we could offer more meaningful choices, right? So perhaps we don't have to reject wellness programs outright. We can just think more deeply about ways in which to enhance choice and then situate individuals to actually make these kinds of healthy decisions that we want to promote. So here's in the literature, we have Thaler and Sunstein, their definition of nudges, and as this tells us, right, a nudge, as they use the term, is any aspect of choice architecture that alters people's behavior in a predictable way without forbidding any options or significantly changing their economic incentives. We had an interesting conversation about voluntariness, right? What does it mean to significantly change someone's economic incentives, right? This is up for debate. And Thaler and Sunstein emphasize that if something is going to qualify as a nudge, it has to be easy and it has to be cheap to avoid. And so then in their book on nudges, they give us some criteria for what constitutes a nudge. They tell us a nudge is something, it will provide some kind of incentive. It's related to, it understands mappings, that is, ways in which people make decisions, right? So how choice architecture operates. It's something that offers defaults so that inaction actually can produce better results in certain circumstances. It gives feedback to allow people to make better choices in the future. It expects error because as human beings, we make mistakes and we miscalculate things, even about our own well-being. And then also it's something that's designed to structure complex choices, and ideally, if it can, make them simpler by providing either more structure or more information. So, to give you all a sense of why these things work, so nudges seek to address and exploit certain quirks in human cognitive functioning. That is, it takes the way we think and then tries to manipulate us into making better decisions. And the primary targets of nudges, as described by Thaler and Sunstein, is things like the status quo bias or inertia. So human beings, sometimes it's difficult to get us to take action, and so one thing a nudge can do is it can promote someone who might otherwise not make a decision to make a better choice, either through default rules or by reminding them to make a choice or making that choice easier. It's something that is designed to counteract temptation or arousal, so cool us off so we make a better decision, right? So if you're not starving, you might not grab that brownie, right? That's a kind of an example that they give. It's also something that seeks to counteract mindlessness or automatic thinking, right? So that is that short-term sort of impulsive thinking so that we can go to the more calculated parts of our brains to actually make better choices for our long-term well-being, right? And so nudges use a variety of techniques to improve decision-making by targeting these kinds of human cognitive functions. So this is something, so the reason it says JRs, this is my nudge typology, this is not from them, this is just the way that I've broken down thinking about these things. One very popular and perhaps the paradigmatic type of nudge would be the default rule, and default rules are things like opt-in or opt-out, right? And so one of the arguments they make in the book is if you want to get more people to donate organs, well, you can make it opt out instead of opt in, right? Another type of nudge is something that I call a prod, and there's different types of prods. So that is something to get you to stop being inert and to make better decisions. And so one type of prod is a reminder. So an example is when you're sending somebody a text message, they need to do something like go to the doctor for a checkup. Other types of prods are designed to be educational, provide more information. So these are things that can also fall under the umbrella of like disclosure requirements. We want people to have more information because that will inspire them to make a better choice. And so, the example I have is a text message informing you that sitting is the new smoking, and you say, I didn't know that, and then you go for a walk, right? And then there's another possible category of prod would be a shaming kind of a prod, something to sort of make you feel a little bit guilty so you're inspired to make a better choice. And someone actually told me that there is an app that will give you a reminder that, 6 o'clock in the morning that says something like, 8 weeks ago, you thought this would be a good time to go running. And then you're like, oh, right? And so maybe that makes you feel, it's a reminder, but it's also, you're like, oh, yeah, I did say I was going to do that. Maybe I should, right? So there's a little aspect of shaming there, right? And then the final type of nudge that, though, as I classify them, would be a bribe, right? So this is, a gift card for losing weight, or maybe some of these other kinds of insurance incentives. So you just literally give someone something for making a good choice. So corporate wellness programs have definitely been construed as a type of nudge, right? So this is I just did a little Google search and some screen captures, and you can see, the idea of wellness and nudging employees towards wellness as something that's pretty popular, right? So how a simple nudge could increase employee wellness and engagement. Then we have people saying, employees are not getting nudged out of their chairs, all that. So wellness programs can actually be understood in terms of being a certain type of choice architecture. That is, they're inspiring these employees to make better choices related to their health, right? So in terms of wellness programs and nudges, right? So we know that wellness programs are things, so among the things they do is they help us identify risks, they seek to prevent disease, and then they seek to promote health. And so what are the kinds of nudges we might see in conjunction with the wellness program? Well, an example is if you get a BMI screening and you weren't aware that you were overweight, that might be a prod to lose weight. It could be educational. It could just let you know, remind you if you're overweight. It could be, to some extent, shaming, depending on how it's framed, right? Similarly, in terms of prevention, health coaching and counseling could also be understood as a prod, as a type of nudge. And then, the corporate wellness programs that offer you like a mug or a t-shirt to join, something like that, or even the more extensive kinds of health insurance benefits, right? So the thing that I want to emphasize is that the idea that we can make better choices is, the animating assumption is that better choices are available, right? So having meaningful choice is a prerequisite to effective choice architecture. And to put it simply, choice architecture assumes people can choose. And so I plan to argue in my paper, right, that not everyone is necessarily nudgeable, right? So who is nudgeable? Well, you're nudgeable if the reason you're not making good decisions are you're not motivated, or you're too tempted, you're lacking self-control, or you don't have enough information or time to slow down and actually think meaningfully about your choices, right? So these are folks that are susceptible to nudges. However, you might be nudge-proof if the reason that you can't make healthy decisions results not from some of these internal kinds of issues like motivation, but rather a lack of access to resources, right? And so this raises the possibility that certain individuals are nudge-proof with regard to making better decisions related to their health, right? So why might people be nudge-proof? Well, the lack of resources could manifest in income, right? You just don't have the sort of means to buy healthier food. It's cheaper to buy something in a box than it is to buy produce. Right? It could be access, that is, a grocery store is not immediately available to you. You don't have transportation in the context of disability. You might not have accessible gym equipment. Time is a resource. Sharona brought up, the single mother who then has caregiving responsibilities, and she might really want to go to the gym, but she doesn't have enough free time to make that happen, no matter how many texts she gets reminding her she needs to do it, right? And so also then, not having adequate resources, whether they come from income, access, or free time, that can lead to stress. And we learned this morning how terrible stress can be for your health, right? This can further impact health and outcomes. And so the point that I want to make to you all, right, is that the people who are nudge-proof, at least the way I'm defining it, are when their unhealthy choices are the result of external, that is environmental or social, versus internal kinds of factors. So which brings us to the question as who is nudge-proof? So I said that, that there are some folks this might not be effective in terms of, lowering costs or improving health, but it could also raise issues related to social justice and access to health care, and that would have to do with some of the populations who have limited choices with respect to their health. So women might have be nudge-proof as compared to men. Why? Well, just from the income perspective, there's a gender pay gap. Also, too, women are the ones who become pregnant, and so the physical effect of pregnancy and childbirth can limit your ability to exercise, lose weight, those kinds of things. Women, too, in our culture are more likely to have caregiving obligations, not just children, but other types of family members, which of course limits free time and perhaps other kinds of resources. Also, too, in the social determinants of health literature, women have said they've had difficulty getting to the gym if they don't have safe and affordable transportation to get there, right, in terms of being able to go if you're trying to work it in between your other kinds of obligations. Also, certain racial and ethnic minorities might have greater difficulties with respect to making healthier choices. Again, there's income and education gaps that are at play. Also, too, certain groups are more likely to live in a food desert. That is, it's going to be harder for them to buy healthy food. They are more likely to live in an unsafe or inaccessible environment, and they're more likely to engage in informal caregiving. And again, this is more than children, this is other types of extended family members as well. So you have women and certain racial and ethnic minority groups. Also, no surprise, people with disabilities have difficulty at times making healthier decisions. Why? Well, there's also income and education gaps there. Also, people with disabilities report reduced time and energy in many circumstances. Also, there's an inaccessible built environment, so going out and getting exercise might be a challenge, or getting to the grocery store that does sell the healthy food. Also, too, if you're thinking about nudges in terms of disclosure or additional information, a lack of accessible communication materials, so making sure that your counselors can communicate with everyone and that materials are available in a variety of formats. Also, too, of course, a lack of accessible and affordable transportation is an issue for people with disabilities. And it may not come as a surprise to you all that there's not a ton of accessible and affordable exercise equipment. So even if people with disabilities want to go to the gym and exercise, they might not be able to use many of the machines, right? So where does this leave us? Well, default rules could still be effective, right? Those are something that depend on this inertia. But people with limited choices will have more trouble responding to those prods or to taking those bribes, right? So examples would be you want to eat healthy, but you live in a food desert. You want to exercise, but you have no transportation to the gym. Or you want to exercise, but you have childcare obligations, right? So my point to you all this afternoon is that some people simply cannot respond to certain kinds of nudges that are present within these wellness programs, right? So this leads to some unfortunate results. So the disadvantages being beyond the non-participation, right? The whole point of these wellness programs, as we heard this morning, is to target chronic conditions that are the result of unhealthy lifestyles. So the folks that can't take the employer up on the particular nudge won't then get the benefit of the reduced chance of a chronic condition. Also, something that's come up already today is cost shifting to lower income, higher risk employees, right? So if we're saving money, it could be on the backs of folks that are more disadvantaged. And these are both things that could combine to actually exacerbate existing health disparities. And so we have this disproportionate impact on historically disadvantaged and vulnerable groups, which raises additional ethical and social justice concerns. So what are we to do? Does that mean we have to abandon wellness programs altogether? I don't think so. I think that we can look to try to construct more autonomy-enhancing policies. That is, when we craft our nudges in conjunction with corporate wellness, that we think in terms of providing people with more choices. So, for example, free healthy snacks or meals at work. So if folks have difficulty getting to the grocery store, maybe this is something you provide as a benefit to someone, right? We had some healthy lunches this afternoon, so on your way home you get to take a salad. So opportunities to exercise at work during the workday. So this deals with some of the transportation or lack of free time issues. Something else would be the availability of standing and walking workstations. So encouraging people to get off their feet when they're actually on the job. Also, too, you could offer some of these medical services at work. An example would be an employer could give you a flu shot. So instead of saying, okay, we're going to remind you to go get your flu shot from your doctor when you might not have time or transportation, you could just actually provide some of the services on site. Right, and another thing that gets mentioned in some of the literature is 24-hour access to medical helplines and websites. So these are kinds of nudges that will actually increase the number of choices and that will create fewer difficulties in conjunction with social and environmental barriers. It also doesn't have to be just in conjunction with wellness. As a general matter, as a country, we could do better in terms of access to free or affordable childcare, access to free or affordable, safe, and accessible transportation, and more flexible work hours. So the takeaways that I have for you all this afternoon is that, just a basic proposition to encourage people to make healthier decisions. We first have to make sure that they have meaningful choices, right? That nudge-proof employees can explain maybe at least some of the limited success or some of the limited effectiveness of corporate wellness programs, and that if we focus on autonomy-enhancing nudges and policies, this might allow us to benefit while avoiding some of these other kinds of consequences. So, thank you all so much.
So, while the slides change, I had not anticipated before coming here this morning how often I would think of Donald Rumsfeld throughout the day. Especially the first session, I think, we learned a lot about known knowns, and then there were different questions about unknown knowns. And at the same time, I think that is actually a really important picture. So I've been to quite a few of meetings on the subject, but I think the picture that you have, which may be one of confusion, is the one that you should be having. I think you asked the question in the last session, so give me a sense of the scale of the magnitude of the problem here. How many people are actually in poorly designed programs? And rightly, the answer was, sorry, we don't know. And that is part of the problem that, and I want to start in a way with this point and end with it too, is that we don't know a lot about what we're doing in this space, which is a little worrying given how important the objectives are, as we heard in the morning.
Well, but wait a second, I gave you some specific numbers of how many are in the wellness.
Correct.
Clinic, so you can't say we don't know. We know to the 100th%.
That's why I said we talked about known knowns and a lot of unknown knowns. We do not know how many people have poor programs, for example. I asked a question about, so do we know how effective the program of not hiring smokers is in helping people change behavior? We don't know. We can't evaluate everything. There are worthy goals here, but we don't have a good evidence situation. But I'll give you a little more examples about why that matters. So the first is this, and this confuses things slightly more, but the point is we're dealing with a very complex type of intervention here. The first is we have a number of different rationales, and I'll talk about those in a moment, why we actually do them. And most of them have actually surfaced throughout the day. We have different types of behaviors that we can incentivize, and those also matter in ethically relevant senses. We have different units that we can incentivize, individuals and groups. We can also incentivize accomplishing certain things or making progress towards certain things or simply taking in information which differs. We have different currencies, so we can use rewards such as honor badges. Weight Watchers works that way, as you know, a very successful program. We can have financial incentives that we talked about mostly, but there are different types that we can use. We can use in-kind incentives, sports goods, and things like that. We can talk about the difference that different types of framing make, carrots and sticks and options in between. The levels we talked a little bit about in the last session too can make a difference. How high or not an incentive is matters ethically and in terms of the effectiveness. We can offer incentives through a lottery where you have only a chance at getting something, or through a hard payment, which comes closer to the concept of the bribe that Jessica was using throughout her talk. But with a lottery, you could say the advantage is we actually decouple the reasonable expectation of getting something that I want to get rather than get healthy from the activity itself. So that in itself matters in program evaluation and ethical terms. Then typically, and we talked mostly about those, we will use mechanisms that work with existing structures, such as providing an annual discount on your insurance premiums, but that is a very long time frame, right? So if you look at much better design programs, they'll often work with daily incentives, where, for example, you entered in a daily lottery if you're on a trajectory to make progress on a weight loss curve or things like that. So those things also matter. And then, very important, we have different types of alternative standards. This is a legal concept, but also one of crucial ethical import. So all those things matter crucially for understanding do incentives work? Because you can imagine there's a multitude of design options that arises just from these factors, as well as are they ethical, right? You tweak a little bit, it changes completely. Okay, so let's talk about the rationales first. Most of all, we're talking about improving health. That's how we started this session, and rightly that should be the objective. That's in the concept of a wellness incentive, right? It's about being well, feeling good. Then we also noticed that there is this other aspect of reducing healthcare cost. Here's a young boy who you see has his eyes on not just the apple, but more the tart. So this is the present preference bias that lots of behavioral economics work is concerned with, where we're just thinking, sure, that might be better for me, and my parents have always told me I should be eating an apple, not the cake. But in so many ways, we all behave like this little boy. We prefer this pleasant pleasure that we can get here to some future pleasant of looking more gorgeous because we exercise more or something like that. So then there's this element of reducing healthcare costs that was very prominent. There is the notion of promoting competition between insurance providers, and I'll give you an example of that in a moment. There is, because most of these programs are offered through corporate providers, and they do offer insurance for about half of the population, including employees and their dependents, there is this other notion of using these programs to improve productivity and absenteeism. And importantly, and I think that's the one we talked about the least, there is implicit or explicit the notion of promoting certain moral values, right? So the 7 deadly sins cast a long cultural shadow, I would suggest to you. Somehow, obese people and smokers, they're slackers, right? Isn't that how we deep down think about them? And they don't have a strong lobby. It's not like you're messing with their breast cancer groups or something. You know, there's not an association that will tell you, don't be so mean to smokers, right? It just doesn't work that way. They're much easier targets, and I think that is one explanation how we can see why is it that these programs are still so prevalent if there are lots of questions about the health promotion potential. So ideally, I'm not saying we can't have it all. Ideally, the stars are aligned and we have everything. We have a program that has better health, that reduces costs, we promote competition, we have more effective workforces, and we promote the right moral values, right? That's possible. I'm not saying it's not possible. But we should be open to the possibility that sometimes one rationale drives a program more than another. And typically, cost reduction might be more important than promoting health, right? What do we do then? Is that a good program or not? Okay, so looking at the types of behavior too, a broad difference that you can draw is between simple behaviors and complex behaviors. The basic point is if you get a flu shot and you give somebody $150 for that because you think it's valuable to themselves and the community, that's easy to do. Yeah? That's a one-off type behavior. It's simple. If you do a one-off health risk assessment, that can also provide you with important, although as we heard, controversial information. Complex behaviors on medication adherence or weight loss or smoking cessation, things that you have to do every day, you have to decide every day, are much harder to do. And that matters in 2 ways. One, because the type of tool that you use to change your behavior is different, and it matters for the question of do incentives work? Well, they will be more effective on one type compared to another. Another important dimension that we have here is the risks that may be associated with them. So recently I wrote a piece suggesting that the very common practice of offering incentives for getting mammograms is not very helpful because getting a mammogram is preference sensitive. It involves risks and benefits. And it is, so I argued, a much better idea to offer incentives for thinking about whether you want to get a mammogram using evidence-based information, which typically is not done. Typically it's presented as a slam dunk, and that is not a good idea given we have high rates of overdiagnosis and overtreatment that you simply need to consider when you do those things. So both the risks and the difficulty of behavior change needs to be considered in thinking, is a program appropriate and is it ethical? Then let's look at the incentivized units. So at one level, we talk about incentives for individuals. Yeah, that makes sense because we have a role to play with regard to how we are doing. Then there's also the group option. So something that employers often will do is incentivize units of groups, similar to the concept of the biggest loser that you may be familiar with. And that can be useful. It can be nice to have a playful element in the workplace, but it can also be extremely stressful for people, right? There's lots of competition, as it is in the workplace, and some people may just not welcome such an additional layer. In very competitive groups, maybe that's nice, but in some cases it may not be nice. Then also we want to be clear that people differ very much in their work settings. So if you're a truck driver and you sit in your truck all day, it's a little bit harder for you to exercise than if you're a gym instructor or something like that. Yeah. So again, something that matters. Yeah. So when we come to individuals, it's common to assume two types of choices that people make. You either use a program or you don't. That's what's at the heart of this question about are programs voluntary. And in a way, this builds on what Jessica was just saying to you. I called this the 5 groups problem in a paper where I started from the assumption to say it's actually a little more complicated than that. Because if you truly look at the types of people that we have who are offered a program, there are a number of ethically relevant differences. The first is that some people will just qualify for incentive without doing anything. Yeah? And we have 3 types of people here. Ones whose goals may be aligned totally with the program. They may totally see how being healthy is a good thing and it saves money, and that's why they do what they do and they get an incentive. So at best they get an ex post reward, but it doesn't change their behavior. Right? The notion of an incentive is I give you something to get from A to B because you somehow don't get there by yourself. So here we're giving something to people who don't need an incentive, but that's the way the policy works. Then secondly, we have people who don't have the same motivation and still get the incentive. Those are the people we all profoundly hate, who never exercise, who look gorgeous, and they don't do anything for it, right? It happens. So those people too get the incentive without doing anything, without alignment of the goals. And then we have the people who we hate even more, who do all the bad things that we want to do, and still they look wonderful. Still they meet all BMI targets, and they get away with it, right? So that's one group, which I call the lucky ones. Then we have what's typically called the responder group, so the yes I can group, who somehow can't make it, give them the incentive, then they can do it, wonderful. That's great. You've overcome decision errors, and it works. And then we have the I'll do it tomorrow group, which was more the group that Jessica was talking about, who face all sorts of difficulties and somehow can't do it, whether it's that they have to work 2 jobs and care for children and their parents, or other constraints that make it really hard to do with where they live. So this is a group that we want to think about quite hard in ethical terms. And then we have the unlucky ones who, let's say they have a strong genetic predisposition that simply means whatever they do, they cannot lose weight, who are outside of it. They don't have a chance. And we also want to think about these. And then we have the refusing. So simply say, look, for me, all those things that you are so concerned about, eating a lot and smoking a lot and drinking a lot, that's what makes life good. I actually like to live that way, right? We have the refusing. So they can just say, do that thing for your people, but for me, that's not what a good life is about. The problem with the regulation is that somehow it treats all those people the same, and in particular, the people who are in the I'll do it tomorrow group and the unlucky ones, potentially the same as the ones who say, I don't want it, right? And ethically, it matters where we draw the line, who benefits from incentives and who doesn't. So back to the legal context, that also, this question came up in the last session here. So a little bit of history. Initially in rules, there was a distinction drawn between 2 types of incentives. Participatory well incentives for which there's no dollar limit. So this is, the basic point is something that anybody can do. Go to a health lecture, do a health risk assessment. There's no dollar limit of how much money you can put on. And then there's what is now called health contingent. It was called something else then, but it doesn't matter. Groups where they said, let's fix this here at 20% of the cost of coverage. As was rightly identified in the last session too, it's important to appreciate that it's not a percentage relative to your contribution, which would make it less for people who are on lower incomes, but it's relative to the cost of coverage. Yeah, and so why was this? Well, there are 3 reasons. The first is at the time when the departments, this was around the introduction of HIPAA, the departments thought about the regulations. They did a survey. They said, let's just see what people are doing. And they found, and interestingly, this has not changed much to now, that employers use levels between 3 and 23%. And then they did a consultation and said which of these should be used. And in the end, they said, look, if we do 20%, then that's good because it allows those people who work with these programs to experiment, and we like to encourage experimentation, and we allow flexibility in design. So we want to do that. And importantly, and this is the ethically important point, it also says that pitching it at 20% avoids that a reward or penalty becomes so large as to have the effect of denying coverage or creating too heavy a financial penalty, right? So a very clear normative conception of affordability that is ingrained here. And we talked earlier about the framing and the difference through which You can implement incentives. So what you also see embedded here is that you can create an incentive both by giving a discount, which is a net reward, that's how much you can vary it, the 20%, or you can increase it by 20%, right? That's precisely why they talk about this possibly becoming a penalty. And then plus the scenario that we just talked about with Sam, you can increase premiums at the beginning of the plan year by a certain amount and offer a reward if you meet the target, which works out to be the same as a penalty. Hence, sometimes it's not so easy to understand whether it's a carrot or a stick, as this little symbol here illustrates for you. So this man, most of you know. I don't mean the one in the middle. We've talked about him earlier, Steve Bird, the former CEO of Safeway. He, through data that was clearly fabricated, persuaded the president, who has his ear here, to say, we need to do something about wellness incentives. And this is one of his slides that is similar to what he toured at the time. And he said, look, if I have a tobacco user, a family with 2 obese smokers, then I'm paying $1,800 more for tobacco and $1,400 for obesity, so a total of just over $3,000. That is, I'm paying incrementally more for these people. And he clearly has this framing now that he says, what HIPAA is good for is to claim back some of this money, right? So he's saying the problem only is I can't claim back everything. So I'm left with what he calls here the incentive gap. In other slides, he called it the responsibility gap. And he says, it can't possibly be the case that I, as a major contributor to society, maybe selling some of the things that contribute to the problem, but let's leave that aside, that I'm landed with this sum here. Do something about this, President. So he also wrote a very influential op-ed in the Wall Street Journal at the time and made this argument. Look, let's focus on fairness here. In car insurance, we have bad drivers and good drivers, and we all accept that the good drivers shouldn't be paying for the bad drivers. So why don't we do the same for health insurance, right? That's his argument. So I tested this well, think about this for a moment, right? Think about whether you agree with that or not. I tested this in a representative sample. So you can now compare what you think relative to what we the people think. And I asked them, this analogy, does that make sense to you? And here's what I found. Turns out the majority of people agrees with that. So 40%, sure enough, don't like it, but the majority likes it. So you have support for Steve Bird's point in principle. And I'll tell you in a moment why this needs to be qualified. One thing that always vexes me when I looked at this is when you break it down by weight groups, by body weight, then what I found is that 60% of overweight people agree with this too, and almost 50% of obese people. This to me is somewhat confusing. Either they are thinking this would be a great incentive, maybe, or a bribe. They may also be thinking, they may be suffering some kind of self-victim blaming, that they don't understand that really is not their fault, but they have so internalized all this pressure that they're thinking this is the right way. Or they may be thinking, I just really like eating that much, and it's fair. I shouldn't be costing more for other people, and that's why I do it. I don't know if you have good ideas, let me know. But still a finding that is interesting. So then the other question, though, is, sure, we can say there should be some kind of surcharge, but how much of a surcharge should it be, right? So this, again, I tested empirically in a sample, and I asked basically 3 questions. There's a very poorly designed program, but one that you find commonly, where you can have the option of the STEM was you being able to weigh twice a year. And the question that people received in randomized order to filter out ordering effects was, first, by how much should the amount be increased if you are overweight, right? So stick scenario. Secondly, by how much should it be decreased as a reward scenario if you meet the target? And third one, what I call the false carrot framing, we increase contributions at the beginning of the year, but how much should we reduce them? Works out to be the same as the stick, of course, but is just looking a little different. So this was the question, these 3 scenarios. The question was how much money should be put on the line? Again, think how much you think should be put on the line here. If you don't like it, think 0. Very meditative, 0, Zen. So here's what I found. Only focus on the bottom line, the red one. This just shows you that the data wasn't distributed all that normally. So you see that for the carrot scenario, the median of all amounts was $200, and for the 2 penalty scenarios, $50. Yeah. Now this is relevant because although we see a vast majority still agreeing with the principle of penalizing obese people, it's really more a slap on the wrist, right? That's less than a parking ticket in New York. Nobody cares about that. That is very different from what Steve Bird was thinking about when he says, I'm paying $750 more, this is what we need to pass on. So this is why it's really important when we think about what does the public think about these things, to think not just about the principle that is at work, but also the magnitude of the penalty that people think is appropriate. So in that sense, we don't see a lot of support for Steve Bird. Okay, so for better or worse, what happened is that, well, for worse, I would argue, that the levels were indeed increased, and we have now the levels of 30% of coverage for activity-only types, and then for outcome-based ones where it's about meeting particular targets, particularly smoking, 50% of the cost of coverage. Yeah? So this is specifically for smoking. Now, note that I flagged to you that in the initial rules, there was this clear notion that if we have more than 20% of coverage, then we have affordability concerns, no longer an issue. Note also that there was, this didn't happen because people said, look, these programs work so wonderfully, if we can just increase the amounts by a little bit, we can do even more wonderful things. It was not that there was evidence that said, this is how effective programs are, we need to put more money on the line. Quite the opposite. There was an explicit recognition in the rules that said we do not require that programs are evidence-based. The idea is they need to be productively designed. I've forgotten the exact phrase, but it is explicitly said they do not need to be evidence-based, again, to encourage experimentation. Now, I'm all up for natural experiments, but if you are starting out that way, then you'll want to say, we also want to learn something from the experiments. And that's not what we're doing. There's no reporting requirements. So we're simply saying, we don't know what's best. We don't want to be prescriptive. Go ahead and do what you want. But yeah, don't tell us what really works. Aside from the wonderful wonderful report that was commissioned from RAND, there's no systematic structure in place that would do this. Okay, so the first thing that changed when we were looking at cost and fairness issue is we have now higher levels that we can use for cost shifting or for creating different kinds of incentives. The second one is that which is the different type of fairness issue that is still related closely to cost, that also came up in relation to the question about how are these programs used. So one analysis showed that if you add free gym membership to Medicare Advantage plans, then it turns out you have a 6% increase in people who report excellent or very good health. As most of you know, the idea with Medicare Advantage plans is that they're not supposed to risk select or optimize their risk pools. However, this is the function that this has. Now, this is an interesting competitive advantage for a private company that offers these services, because it works as a marker of people who have lower levels of morbidity, right? But very different from saying we want to use this to increase health. Then we have, so this is a version of cherry picking, right? Economists always have these wonderful terms, so I took a life-affirming picture here for cherry picking people for Medicare plans. Then we have lemon dropping, which is the opposite as it's known. And so here the idea is you just get rid of people in your risk pool that you don't like. And here's one way in which you can do this. This is data from the Kaiser survey, employer survey. So you see half of employers use health risk assessments, and 3% don't just use them, but they require that you do them if you want to access the employer's health insurance plan, right? So that can be nice. If you think there's some information that I would want to share, maybe because I feel very sick, and you think maybe I'll shop around and I get better insurance privately, then that's quite nice if you're the financial officer for the health plan and you're thinking, I'm rid of these people now because they're looking for their own insurance. Yeah? But that's another function in which you can use them for lemon dropping. Then there's this version where you could also say, if you very actively publicize your programs, such as you're not hiring smokers or you don't like obese people, then maybe a lot less people will apply to you in the first place. Have you changed behavior at the population level? Probably not, but you're not dealing with the problem. Leave it for other people to deal with it, right? That's one other option through which you can use these things. And there's a question, is that an ethical issue we should be concerned about? Can be perfectly legitimate for employers to behave that way, but can also be tricky. Just for the record, because I asked this question earlier, I'm not very fond of not hiring smokers. Okay, so the key ethical question is really at what point we have inequalities, as Jessica mentioned just now too, in the capacity to use programs that mean it's really unfair that we offer these programs, leaving aside this question of voluntariness. Opportunity of choice is the key point. Somewhat different, but also relevant to me, is this question of how much does the motivation align, have people actually change their behavior, right? But the key thing really is opportunity of choice here. And my key message in relation to this is exactly this. And this is much as we have said lots of regulations we don't like, these are the final rules for wellness incentives that came out in 2013, and they made a very interesting and important distinction that we talked about in different contexts, but just to walk through this table with you again briefly. So first is the distinction between participatory and health contingent incentives, right? Participatory is what everybody can do, gym membership, diagnostic, testing, etc. You don't need an alternative standard because everybody can do it. And then we have the subdivision of health contingent ones, where on the one hand we have activity-only programs where you're saying, well, walk, exercise, and we want to have a sense of how much you walk, but we don't tie the reward or penalty to whether you accomplish the goal, right? So we can vary cost by 30%, and we need to provide an alternative standard if it's medically inadvisable or impossible, is sort of the language in the law, to accomplish the standard. So if you're pregnant, it doesn't make sense to achieve certain goals. For the outcome-based examples, we have a really interesting concretization of the alternative standard that needs to be provided, because this goes very much to taking into consideration the obstacles that we can have through social determinants in health and others. So here's what the text says. In those cases, a reasonable alternative standard must be provided, and I have emphasized this here for a reason that I'll come to in a moment. A reasonable alternative standard must be provided to all individuals who do not meet the initial standard to ensure that the program is reasonably designed to improve health and is not a subterfuge to underwriting or reducing benefits based on health status. And the options that are given are this: offer something else that the person can achieve. They specifically give the example of smoking cessation, where sometimes you need repeated efforts. You try once and you need to try again. So give people a choice to do it not just once. Maybe they fail once, reward them for trying, and then give them another option to do the same program. Or the physician can make a recommendation, or you give them an activity-only program, or a participatory program, or a waiver, right? Those are the options. So this really goes very much to the core of the fairness issues that Jessica was emphasizing, that I addressed when I looked at the 5 groups problem, that not everybody is at a level playing field when it comes to achieving the standards that are at work. Now, the reason why italicized provided is because, what does that mean? The past regulation required that people come to the employer and say, look, this doesn't work for me, do something for me. Now, if you already feel on the back foot because you're not regarded as healthy, you're put in this petitioning situation, right? That most people, especially if you feel you're also not super at being self-efficacious, are probably not likely to take up. Nonetheless, it probably says in the small print of your wellness program, if you don't like this, come to us, we'll help you out. So the employer has done their work. So much of the ethical weight here hinges on what does it mean to provide this? How much are you proactive? So the policy options at this point are, let's just leave everything as it is, that's great. Most of you didn't like certain pieces, so that's unlikely. We can also say, let's modify it a bit. I would say modify the alternative standards is a key thing we should be doing. You could say, let's just target some people, right? That came out in the first session, I think, to say, maybe let's focus only on the high-risk people. But then you have issues around stigmatization that also are not trivial, I will just suggest. Or you could say, let's just scrap the whole thing. I guess you were veering a little bit more towards that, and certainly lots of people make that argument and say, let's just do social determinants of health. Let's have healthy food for everyone. So what I think is, I'm probably somewhere in the middle of these two options. I do think there is an obligation to provide programs because they have in many cases shown very clear potential to overcome very difficult behaviors such as smoking cessation and addiction. And it seems bizarre to me to throw this out. They have a lot of potential and we need to harness it. So the key is to empower and not to victim blame people, to be more proactive about alternative standards than we are at the moment. And this is where I want to draw the loop to the beginning. The thing that to me is infuriating is that we have this wonderful set of natural experiments and we learn very little from it, right? So CERN study had 600 employees. How many are there? Gazillions, right? We don't know what anybody is doing. And this is very poor for a field that we've all recognized, and you've made the case very powerfully and persuasively, I think. There's a lot at stake to improve individual welfare, possibly to reduce costs, but we are not in a situation where we can really learn what is best practice. So that's not good. So one idea that I published in one piece is to say, why don't we use the CDC as a neutral repository? They already have a workplace wellness scorecard system. You could have some reporting of key metrics to them. And importantly, I think when we do these evaluations, we don't just want to look at the effectiveness, but also at who benefits and who doesn't. So it needs to extend to both the ethics and the effectiveness. So I'll leave it there, and now we have more time for general discussion. Thanks so much.
As before, folks have questions, wait for the microphones to come around. I see that there are two in the back. While the microphones are making their way up there, I'll ask some questions, but I'll first ask the panelists if they wanted to make any comments about each other's presentations before we get to questions.
Yeah, so kind of going back to our comparing tobacco use and obesity earlier this morning, and the fact that tobacco use bans in terms of hiring are something that's relatively well accepted, and obesity bans seem rarer. I was wondering if there was a study similar to the one done on the obesity responsibility, by weight, in terms of similar kinds of penalties for smokers. So do smokers say, yeah, you should charge me more because I'm responsible for my behavior? And then the other possibility, it seems to me, that why obese people would agree to such a thing would just be stigma, right? And that so sort of self-imposed stigma as a result. Say, yes, no, I am a bad person. You should definitely, which gets to the moral part of your
Right.
presentation.
I'm not aware of it. I have some work in the planning that addresses those points, but if anybody else has anything to contribute, please let me know. Actually, both points, both the qualitative assessment of what's going on in the obesity scenario, as well as the smoker, and actually a whole lot of other cases where you can make similar arguments.
Just to follow up on that, in the environmental risk literature, there's a lot of work showing that people are very bad at quantifying risks, generally slightly better at quantifying risks that they themselves are exposed to and that they have some control over, right? So older people are much more aware of the risks of falling than younger people are, for example. And there's a lot of work trying to figure out how do we improve decisions about risk by improving information. And so I'm wondering, is there any reason to think that the results you showed on what people think about the extent to which we should cross-subsidize others, whether we should cross-subsidize more costly individuals that are more costly perhaps for reasons that we think are blameworthy, is it all affected by or would be affected by greater information about what the actual increased costs are of someone being obese, or on the other hand, greater information about the fact that some percentage of obese people are obese due to metabolism or other conditions that they may not have control over?
For sure. I'm absolutely sure that would be the case, but the main reason for this was to deliberately go blank at people and say, here's a proposal, because that's the situation you find yourself in if you get this thing offered from your health plan. You don't have a fact sheet about the economic burden of obesity, and you still will see some response. So that was what was the purpose here. And I'll just leave that.
We have a question from Dr. Royce. He made some questions in the back. While the microphones are getting up there, I'll ask Jessica a quick question. One, I guess, takeaway from your talk was that nudges could be more effective and could reach those that might be otherwise nudge-proof the more we can offer a broad suite of options, which seemed, I think, to echo some of what Dr. Roizen said earlier about how some people, curves might work for some people, personal training might work for somebody else, other opportunities might work for somebody else. And so my question is, and Dr. Roizen may want to comment on this as well, that would seem to suggest that very large employers, the Cleveland Clinic Foundation and Cleveland Clinics with 48,000 employees, have an easy time of doing this because they have the economy of scale where they can offer a wide range of opportunities, a wide range of services and the like. But the small employer, those individuals that are contractors or self-employed, aren't going to be in a situation to take advantage of that. And so what do we think about that? Is it just that, hey, there's a benefit to being with a large employer? Do we think the government either should or is capable of offering the same sort of opportunities in the same sort of way? There's a literature saying that employers, for a whole bunch of reasons, are differently situated than government entities to play this sort of role. And so I'm wondering how you would apply your analysis to small businesses, self-employed, and folks for whom this cornucopia of wellness options really might not be a realistic thing.
Sure. So in the course of Dr. Roizen's presentation earlier today, one of the places he ended is when are these when are these programs effective? And one of the criteria was a lack of barriers and making it free. Right, and that's where I was like, aha, yes, this goes along with what I think I'm saying, right, in terms of being nudge-proof, because that is the key, that people don't have barriers to actually making the choices, and that it's something that is going to be that doesn't impose additional costs on the employees. So I definitely think that larger employers are better situated to incorporate these kinds, what I've described as, the autonomy enhancing sorts of nudges. But I see this problem as being something that's situated in the context of the social determinants of health more greatly, right? So when you get to those smaller employers, yes, I do think that this is a place where health policymakers and the government should be willing to think about, if we want people to be healthier, if we want Americans to be healthier, it doesn't make sense to have the conversation just be between an individual and her doctor, right? We need to go into neighborhoods and see what kind of issues are there and make sure that there's, usable sidewalks and access to grocery stores. And so I think that, with respect to those smaller employers, it then becomes a conversation about what is a larger problem, I think, beyond the wellness programs.
Tourism.
I'm bothered by two, if you will, the approach of let's stop this with, in some of the, if you will, legal sense, and some of this, because we have a problem in America. The world has a problem. We will not be able to afford the chronic disease. And so it seems to me one of the outcomes I would love to have discussed is what happens if we don't do something to stop it. So where we are now is out-of-pocket costs are increasing greatly, and they're a huge part of the income inequality, and they're the stopping of this, if you will, via other, whether legal or other thing, is in fact making the very issue we wish to solve much worse. And so I don't know the answer to this if it isn't corporations and this broad range of wellness programs. I'm really worried that our social fabric deteriorates. And if you look at the incidence of chronic disease, we only got 8 years on this at most before we hit a tipping point of rationing. And so I think what I want to hear more of isn't why this isn't working or what, but more of what could work from these two, if you will, what can work rather than, and what can get people to change, and maybe you can have some of the other authors or some of the other speakers talk.
Oh, so just to be clear, in terms of my position, is not necessarily, it's not that we need to walk away from these things and completely discard them, and that wellness programs are never effective, or that nudges are never effective. They are effective in certain circumstances, but I think it's up to individual employers to look at who their employees are, and in a situation, earlier today, I'm forgetting which one of the presenters made the joke, right? If you've seen one wellness program, you've seen one wellness program, right? That these things are incredibly diverse, and that you need to make sure that if you're offering these kinds of incentives, these, or prodding people or trying to bribe people, that it's actually a choice that they can make. And so I think that from my perspective, it's not that, we should just ignore this and it's not a problem. It's rather that the individual employer, when it's constructing its wellness program, needs to say, okay, are my employees of these populations that might not be able to go to the gym? Is an off-site gym not something, that's accessible to them? So it's just a matter of, I think, tailoring it to those populations to make sure that we can all benefit from it. Because my concern is that the folks that can't take up those incentives, right, are going to get left behind and become chronically ill anyway. Mm-hmm. And so we just need to figure out how to bring them into the fold and allow that and facilitate better choices, right, so that we can all move along towards wellness and we're not, substantially disadvantaging particular populations.
I would agree with that, and I certainly also, that's why I ended on the slide to say we should offer them, but modify them. My key concern is to not leave anybody behind, and I certainly would advocate that employers have a major role to play in this project, but that means they need to know, what should I do? And we can't know that because we have a very poor data situation. We can go to the published literature, heavily biased towards large organizations. The question you just raised, not all is transferable to small employers. Only successful studies get published, publication bias. Not all the programs that are implemented are even evaluated, right? So we really know so little. That's why we need to really think hard about what structures do we have to enable all employers to do what you are saying we should be doing. And then the other thing too, though, is that precisely because employers have this unique opportunity, I think they can abrogate responsibility, for example, by not hiring obese or smokers. But as you said in response to my question, why shouldn't you be hiring obese people? You said, well, we can do something with them. You can do exactly the same with smokers. You can work with them and not say, well, now you're on your own.
And
No, let me make sure. So anyone who applies to Cleveland Clinic who is a smoker gets free smoking cessation and then gets re-entered into the employment pool.
Right.
So we do something
If-
with every one of them if they want.
If they succeed.
if they succeed.
And success means, no NRT, right? Because if they're using nicotine gum or a patch, that's gonna show up in the blood test.
Well, they get 6 months of NRT.
But they have to be able to, take the,
It is they have to be off of it at the time they test.
right, so they have to have completely,
Succeeded for 2 weeks.
And they must feel confident that they can accomplish this in the first place if you think it's a recognized addiction. Vastly more smokers want to quit than accomplish it themselves. So you lose nothing, I would argue, by saying, we don't judge you at the point of hiring us, just come work with us and then we'll help you quit.
And also, I think that going back to your question, right, in terms of is this a problem where we want to vest employers with primary responsibility here, or is this a place where we need more government intervention? And, I don't necessarily foresee that happening anytime soon, since we're still fighting battles over the Affordable Care Act. But, I mean,
We can't even get an allocation for Zika control.
so, but
That could decimate all the senators who aren't approving it.
Emperor Trump's health plan will change that, though.
right, but this is the big question, right? Are these the right entities? If our true concern is wellness, are these the right entities, right?
Lauren?
in the back.
Yeah, thank you very much. Wonderful program. We're getting towards the end. I guess everybody's getting weary, so I'm going to ask a long question and you try to make it a short answer. You said something about government intervention. Oh, my goodness. We've been on the road to serfdom, but I don't want to get into a political debate with anybody in this room. In Fairfax County, Virginia, where I live, 2.5 years ago, a program was started that followed 4 years of community exploratory financed by NIH, and the program is called Live Healthy Fairfax. I urge you to go to it. I urge you to read the report. We're lawyers, some of us here. There's a difference between declaratory policy, like the president's wife saying, get up and move, and mandatory policy. And the heart of voluntarism is, as you guys have presented it, we get it, so let's go do it. Read what Live Healthy Fairfax is all about. Every employer, private and public, NGO, nonprofit, for-profit, etc., every community association is contemplating with action plans what they ought to do by way of building community spirit and shared outcome as a declaratory policy of our equivalent city council. We call it a board of supervisors. It's a very well thought out policy. It's very slow to implement. It gets bureaucratized. I have my hand on the pulse out there. They have quarterly meetings with grass tops leaders throughout the 1 million person community. So it is happening. There is a wave happening. So my question to you is, what do you want to see happen, not in 8 years, as Dr. Royson has pointed out, but in 1 year, 2 years, or 3 years? What do you want to see at the University of Houston? What do you want to see at the University of Pennsylvania? What do you want to see for the state of Texas or the county that you live in? Ditto for Philadelphia.
So I think what you've tapped into in terms of the Live Healthy Fairfax is that, at least in the short term, a key component here is community engagement, right? So this is the sort of thing that you're talking about. And if you go to the social determinants of health literature, right, this is something that where we want to address these kinds of problems, not just, from the top down, but also the neighborhoods themselves going out and, increasing green space, trying to make things safer, getting people outside, or trying to bring businesses into the neighborhood. So I think that, while we're waiting, right, to see what may happen in terms of, governmental intervention, the possibility that the most promise in the short term, I think, will come from communities getting together and, using information that they have access to say, yes, we want to have the ability to make healthier decisions. And I think that is something that gets played out in the social determinants literature.
My short answer is I will read the Healthy Fairfax plan.
So,
Soren had a question, and then Professor Bagenstos.
Yeah, I basically wanted to agree with you. What troubles me with these high-powered incentives is that they are extremely regressive, because not only do they hit the low-income earners harder as a percent of income, and it's also the case that unhealthy behaviors, for better or worse, are concentrated in the low-income population. So it's a regressive policy, and I think we already have too many regressive policies around health coverage. And so I think we can only justify these high-powered incentives if we have clear and unambiguous proof that wellness programs do help everybody, also the ones that are so socially disadvantaged. And at least the independent research so far has not shown that. Well, so that's basically where my skepticism comes from.
Okay, I mean, I completely agree with you entirely with the gist. Just let me give you one example that study, a very nice randomized controlled trial that Kevin Volpe and others did on smoking cessation, where a 3-tiered incentive to quit smoking of $750 helped achieve 3-fold higher quit rates than routine standard of care, right? So there's, if anything, in terms of regressivity here, lower income people benefited more. I'm all up for that. People overcame a really hard health behavior, and it worked. So if you're asking for one example, here's one, and that to me is, it's a very solid study. There's no question about the fact that that works. I completely worry about the real world, because some of you may know the story of how this evolved. So this was done with General Electric, and they said, this is great. We have solid science that tells us so little money helps us have all these people not smoke anymore. We want to roll it out to 150,000 employees. But then, does anybody know what happened?
No.
Turned out the non-smokers said, wait, these people who are smoking, I have not been smoking all my life. You're giving them $750? So what GE said after they got the big backlash is, okay, let's give the smokers $680 surcharge without any evidence, right? Now, they could have outreached, they could have explained how they gain to profit from this too, given we are also persuaded by the cost savings, and they didn't. So the realpolitik is scary in this space, but I do not think that the basic principle of incentivizing is one that leads you to penalize and victim blame. So that's why I think why we want to harness the good in here and minimize the hazards, as this conference is called.
Well, I'll go to Sam either way. All right, Sam.
All right, so just very quickly, I think these are really interesting papers, and the whole discussion's been really interesting. I mean, it does seem to me, and actually, Harald, your last point really hits on what I think is sort of the crucial consideration here, that as we move from the pieces of evidence we have to what actually happens, I mean, we find a very thin evidentiary base, often then getting way outstripped by the actual implementation, and the implementation being skewed a lot by what you talked about early, the sort of moralism. And the moralism has a particular class basis to it, right? I mean, so it's not surprising that smoking and obesity are class markers in the United States of America now. And
Wait, explain that to Sarah and I. We're foreigners. So isn't this a classless society? I always thought. Okay.
I thought Europe was classless. No. Well, maybe if Bernie wins, maybe we'll be classless in America. I don't know. That's what I'm told. But in any event,
Trump's win, we'll also have lost a lot of class.
I got nothing to say after that. I mean, I do think that that's really a really important consideration here, and I do think it makes. So we get from a diagnosis that is, look, chronic disease is a real problem, and chronic disease is associated with a set of behaviors. We get very quickly to a lot of very exclusionary and stigmatizing and penalizing policies that relate to that. So there are lots of ways that you could encourage people to quit smoking. Not hiring smokers is, so I'd like to see the evidence that that's a better way of doing it than any other way. And then we could actually have what I would think would be appropriate, which is a democratic debate about whether the costs of that are sufficient to outweigh whatever benefits we get from it. But we get to very quickly these very punitive kinds of exclusionary approaches, and I think that's the problem. So I like a lot the call for more data. I have a feeling, data is the friend of people like me who think that a lot of these programs go too far, but I could be wrong about that. And if I'm wrong about that, great. Then let's have an argument. And I think, our democratic we can't move to an anti-democratic place and say the answer is big employers should decide because Congress is dysfunctional. I mean, we are a democratic society, and these are fundamental questions of value, right? It's what do we think it's worth to achieve very important goals? What are the ways that are going to achieve it most efficiently, and are those costs we're willing to bear? And I think we just can't, so someone said, well, I don't want to make this political. There's no way to avoid making it political. I'm sorry. It's a deeply political question. So that's my comment.
Well, that's actually the other beauty, of the reporting requirement that I usually call it the effect of the benevolent pillory. So one thing is that it really helps us understand what is good data. But if you think about, we had these questions earlier about leadership too, right? Or the prizes that people are getting. So there is something else that corporations really like, which is being seen as a leader. You won't like being seen as a laggard. If it turns out you have the most punitive program of all in your county, in your state, whatever, that will be will be a very helpful incentive, as it turns out, for companies to make sure, well, okay, let me see, what are others actually doing? So that's why I agree with the concern, but I also have a feeling that it is manageable in principle.
Yep. And I just wanted to say on the point of exclusion and stigma, one of the benefits to these nudges is that they're supposed to be at a low cost, right? So you send a text message, and once you have that in place, that's not such a big deal. But and this also relates to the need for data. So there's the assumption that this does not create any sort of harm. But then I wonder if you're a person who then is in this group of people that I define as being nudge-proof, and you want to make the change, but you constantly are getting prodded with something you cannot do. If in fact there is some sort of a cost there in terms of your self-image or creation of stigma, if your colleagues are able to make that particular change. So I think that there is definitely a deep undercurrent of morality here that is not necessarily always teased out in full in a lot of the writing about this.
If I could just chime in and just from the standpoint of kind of be careful what you wish for in response to Sam's comment. One of the central features of the Affordable Care Act is effectively the elimination of medical underwriting. And quite a few folks involved in it, perhaps most infamously Jonathan Gruber, said if it had been sold on that basis, it would not have passed. One argument or one characterization of wellness programs is that wellness programs in part are a way of partially reintroducing medical underwriting into employer-based plans, albeit in an indirect and perhaps not always transparent way. And then some of the data that Harald showed suggests that at least a significant portion of Americans like medical underwriting or things that seem to correlate with medical underwriting. And so I would just say that, it seems that there's this underlying tension in how we want to think about who should bear what costs related to health and wellness, and what we have enacted into law and what we are seeing and perhaps seem to support on the front lines aren't exactly in line with one another. And if the point is to have a big democratic debate about all this, some of the biggest advocates of what we did have said if we were honest about what we were doing, it would not have happened. And well, no, but I mean, the point is just that, I'd be the first to argue we don't have direct democracy for reasons, and this might be one of them. But that if medical underwriting is something we want to eliminate because we think as a society that certain degree of cost shifting is something that's part of being a broad community and is a national community that we all should be in to some degree, one pool together, well, then that probably tells us something about the extent to which we want to be encouraging or pushing large employers to adopt certain sorts of programs. And if there's resistance to that, then there might not be the degree of consensus about how we want to deal with health costs and consequences that we hope or would like to think we have. And I just think that's an underlying tension that bubbles up here and in a lot of these discussions. Dr. Roy?
I have 3 comments on
Please.
things that are raised. So one is that the group that has the greatest chance of benefiting is those with illness, with chronic illness that we're able to reverse the early stages of, and they become vigorous the rest of their lives and become much better. So we spend much more money on, in fact, if you look at our own spending on wellness programs, it is magnitudes greater on those with a chronic disease that we're trying to stabilize or reverse. The second is a point that you raised. We have the hardest group is, in fact, our lowest income employees who are working 2 or 3 jobs. And it is something that we and a couple others are working incredibly active on. How do we get more engagement? How do we get more success in that group in reversing disease? The third, what? No.
It might not be a lack of
Well,
engagement.
in fact,
It might be a lack of resources.
what the Cleveland Clinic did by, look, I'm going to toot Toby's horn, if you will. What Toby did when he was successful with this program, with the savings, is he raised the minimum wage of every employee at the Cleveland Clinic. So everyone in the lower economic group got about a 30% raise last year spontaneously. And forget that point, if you will, because that wasn't one of mine, if you will. I just wanted to, I was just saying it. But the other thing is on smoking. When we went and announced we were going to go smoke-free, not hiring smokers, we did it publicly. We also said we would, in fact, publicly and free smoking cessation to anyone in the county who wasn't otherwise insured for it. And what happened was the only county in the state of Ohio with a decreased smoking rate in the next 6 months was Cuyahoga, which had where we offered this program, which was a major decrease, much greater than the numbers we in fact affected, probably because the thought was that it got publicized on the harms of smoking so much. So I believe that that's the only data point. The rest of Ohio went up in actually smoking rates because a prior governor, not this one, took all the money out of prevention in smoking.
So I have a question. One of the issues that I have not heard discussed today is the impact of these programs on the patient-physician relationship. In particular, those programs that require or expect the employees' participation means going to your personal physician, creating a wellness, some kind of a compliance program, and then expecting the personal physician to report back to the wellness program, i.e. the employer, whether or not the employee is complying with the program.
Max, I did comment on that. And all we have is anecdotal data, and it shows that the physician-patient relationship gets much stronger, because instead of ignoring what the physician is saying, I'm not going to manage my blood pressure, I'm not going to do this, and say, get me to 5 normals because I want the reward.
I would be interested in seeing
We've got a lot of
information because, I mean, that is such a frank conflict of interest on the part of the physician that I cannot believe that it would actually be acceptable to people if they understood the pressures that they were actually being put under.
So
I wondered if any of our commentators, excuse me, I wondered if anybody else had any comments on that.
I did a study actually on that very question. The conflict, as I understood you, is that the physician has a primary obligation to the patient that should be to do with the care and not to do with their financial advantage or disadvantage. Now, in the best case scenario that you described is you're getting somebody a financial advantage and better health. That's wonderful. But it's also possible that if a patient says, sorry, you didn't meet your target, you're going to have to pay $500 more, then that puts physicians in a policing function that I looked at it for both obesity and colon cancer screening. I did a survey with 25 physicians, qualitative interviews, so no big data. But I can tell you that the picture was mixed, so that some physicians actually liked that function and said, well, that finally gives me teeth. Finally they have to listen. It's not that they're saying, doctor, you help me, but it's that saying, oh, now I have to listen to the doctor. And others said they really didn't like it. At the same time, that's not the only case where physicians make such decisions, right? There's lots of disability care, sick notes, right? I mean, physicians are in these situations quite a bit. But I think I echo your worry, and that was certainly what came out of this, is that it does interfere with the physician-patient relationship, maybe in a good way, but maybe in a bad way. So it's another thing that the intervention raises that we'll want to monitor, and that is somewhat below the radar of the bigger ticket issues where we're saying, well, we can measure economic disadvantage, but it's much harder to measure what goes on in these kind of situations. So I agree it's something worth paying attention to.
Just out of curiosity, in those interviews, was there any, did any of the physicians in those interviews raise concerns that the benchmarks were poor proxies, you know, so that they might be proxies that work well over a large population, but that may, in the cases of specific individuals, not actually be good measures of health? So I'm thinking of, for example, BMI.
Yes. That was certainly one of the things that came up for BMI, yeah. For colon cancer screening, it was very different because this was done with oncologists, and they all thought this is, for the age group, ubiquitously good. As you know, again, one of the crazy things, there are lots of, not lots, but at least one health plan that offers colon cancer screening for 30-year-olds as well as breast cancer screening. Insane, but it happens. Again, shows you how crazy the world of wellness incentives can get. But for the right age group, there was no question about that, which is why I paired the two, whereas for BMI, indeed, that was a concern that people said, look, I have lots of people who are overweight, but even if you look at the studies that looked at this in more detail too, the correlation isn't all that clear, and certainly primary care physicians very often know how patients otherwise are doing very well, and they just felt this is unfair, and it doesn't make sense because they're doing fine.
Yes, if I could, to introduce a subject, you use the word exercise. Everybody uses the word exercise. I'd like to use the word sports and sports activities. So I'm going to take an informal survey. Who in this room has a seasonal or a weekly sports activity that they do? Please raise their hand. Tennis, golf, volleyball, whatever, swimming. So I happen to meet Professor Melman. This is not disclosing anything that is totally confidential, in Vail, Colorado in March. And by accident, a couple of days later, I met an applied economist who gave me the following statistic. About 10 to 11 million Americans are in skiing every year, and in winter sports, the total is about 20 million. I guess that's snowshoes and cross country and ice hockey and whatever. Why do we not see, with all of the data points that we have, an evaluation of the level of sports activity instead of 30 minutes of exercise 3 days a week, so that people get this as a model of appropriate health-inducing, health-conferring activity that is part of their daily routine? There's the idea of being a nudge or nudging, and giving people information and using the carrot or incentivizing them because they understand their own well-being. Gentleman over there raised right in the beginning with a question, if I may reference that. Well, you're not measuring people's happiness. You're not measuring their motivation. You're not able to measure their sense of well-being. And if you don't measure it, it's just a phrase hanging out there. So I'm wondering if encouraging Americans to get up and move by telling us what sports activities we do across the country and what neighborhoods, what communities, what counties, what states are deficient in what they should be doing because others have figured this out.
Well, so actually what you're describing, if there were such a policy, would definitely qualify as a nudge, at least under what Thaler and Sunstein, sort of one of the human cognitive quirks that they discuss is that human beings are very susceptible to framing. And in terms of framing, we also care very much what everyone else is doing. So I think if you manage to, you know, if there was an impressive number of people playing sports and you managed to say like this number of people engage in this number of hours of sports, and, you know, then that's something that might make other people will see that as evidence that perhaps they too should be engaging in that same activity. So that might be an effective nudge, assuming, of course, that they have access to equipment and time and other things to do that, obviously. But yeah.
Well, that's the other thing. Right. So that's the other thing that I think is ringing through here, right? That effective solutions to behavior change are probably as idiosyncratic oftentimes as we are as people. So this works for you. If I'd hear that, I'd be thinking, yeah, that's interesting, but it wouldn't do anything for me. And you made the point earlier, I think, too, in the multitude of programs that you feel you need to throw at people, which also seems right to me. because different things work for different people, right? That's especially when it comes to behavior change. Think of what crazy things we do. I used to do sports with somebody with whom I shared a changing room often, and he wanted to quit smoking, and I saw that he had a cigarette pack in his jacket, and I said, wait, I thought you quit smoking, and this was in Germany. So he said, well, see, the thing is, whenever I go by vending machines, which you don't have here, but we had at the time in Germany, I get this craving. But if I have the cigarettes on me, I don't have the craving. And I thought, that is just crazy, but it worked. I completely knew that he quit smoking. I know another, actually an academic, a senior academic in behavioral economics, who asked his wife to hide the cookies from him in his house. You know, things like that happen. We do crazy stuff, but we know what works for us, and hence we got to be mindful of that in rolling out uniform interventions that may not work for everyone.
Right.
This will be the last question.
Sure, and then you're going to offer concluding thoughts. Right.
I just wanted to follow up on the comment in terms of considering sports in your overall exercise program. And one of the things I did not hear discussed, although we did talk about third-party vendors and so forth in terms of managing corporate wellness programs, but in particular in this county, a company called Vitality, which is apparently very aggressive in this market and very successful. And also some types of programs such as what we have here in Cuyahoga, which is Corporate Challenge, which is a company named Hermes, and they run it during the summer, obviously because of Cleveland's seasons, and I'm from Florida, so this could have been year-round for us, but in Cleveland it's during the summer. But those are actually very sports-oriented, and I know that it's the anomaly, but the aha moment that Dr. Roising mentioned, where there is the person at work who had an incredible life-changing experience, a tremendous weight loss, or moved from that to being an athlete, and that at the end of the day, it's those types of direct experiences or direct contacts which ultimately might be a motivating factor. And that's kind of what I haven't heard talk of about those other types of programs where it might start at work, but it moves to an overall lifestyle change, which arguably won't necessarily be measured by some of the dashboard points that we talked about today.
Yeah, I think the idea of building sports and sports as part of the workplace into wellness is an interesting idea for some people. That would be a great nudge, I think. So I want to thank all of our speakers, both our enthusiasts and our skeptics and critics. You gave us a lot to think about today, and you fielded our questions and comments. And I want to thank the audience for giving us such attention and also for their questions and comments. I want to thank Nancy Pratt, Brian Galviano, Tron, David, and Martin for helping us to handle the technical and administrative aspects of this. So a round of applause, please, for all our speakers. There will be a reception right after this in the rooms around where we had lunch. If you stay on, if you want to stay sitting here at 5 o'clock, or you can come back, there's going to be another presentation. The UN High Commissioner for Human Rights is going to give a lecture in this room on global human rights at 5 o'clock, so you're welcome to stay for that, and there'll be another reception after that. Brian, is there an activity code for this?
Yes, where you register to come in, there's a table, go there, and they'll have that for you.
And yeah, and are you collecting the CLE forms, or?
No, they do at the registration.
Okay, at the registration table? Thank you.